to assess as far as the extent of the burn. We talked about the depths, but more importantly, when we start looking at the surface area that's been compromised, that's going to dictate a lot more treatment in certain cases, and it's also going to dictate in some cases where we actually take this patient. And that gets into using the old rule of nines. If we're looking at a typical average, if you will, adult, then we're going to consider the body surface area like this. We start off, we're looking at the rule of nines, that their head, the entire head of an adult, is 9%. If you take the head and divide it anterior posterior, so the anterior portion would be 4.5%, the posterior would be 4.5%. The trunk, right? Now the trunk in and of itself is the chest and the abdomen together. So if it's just the anterior part of the chest, that would be 9% to like the diaphragm, and then below the diaphragm to the pelvis would be another 9%. Or if it's the whole thing, it's obviously 18. Flip the patient over, same thing. From neck down to roughly about the pelvic area on the back, that's a whole 18% as well. Each arm is 9%. Anterior is 4.5, posterior is 4.5. When we look at the legs in total are 18% for each. So it's 9 for the anterior, 9 for the posterior, right and left. And then you have the 1% for the genitalia area if that's been involved as well. All that should add up to obviously about 100% if I did my math right. Now, when you get into the smaller children, so school-age kids, toddlers to a degree, somewhere around those age ranges, or again, that smaller adult, now we're looking at some differences as far as proportion of head to body. So we change the percentages a little bit. That being what it is, now we look at the whole head of those children at 18%. So now it's 9 for the anterior and 9 for the posterior, a little bit bigger. Still the same numbers for the trunk, so it's still 18% for the front, 18% for the back. Still the same percentage for the arms. So 4.5 on the front, 4.5 on the back. The legs being a little shorter, we change that percentage a little bit. So now it's 7% front, 7% back, anterior, posterior, and then still the 1% for the genitalia. It's because we're compensating for still that kind of that larger head in comparison to the rest of the body. Now, we get down, God forbid, to the infants. So kids that are around 1 year old, maybe a little bit less, maybe a little bit older, just around that 13, 14 month range. So now we're looking at still huge head, balancing on a toothpick with a small body. So now the head of the infant is still 18% total, so 9.9. The arms are still same thing, 9 total, so 4.5 on anterior or posterior. The trunk is still 18. Legs, 14%, so 7 and 7 on both sides as well. Okay, again, adding up to that same amount. Not a whole lot of difference between that infant and child, but again, you've got a little bit larger surface area on that head in comparison to the children, so we make those differences there. So one thing to also consider is you have a person, an adult, of short stature. So maybe they're the same height as a 10-year-old or an 8-year-old or something like that, perhaps. So you want to use that same correlation when you use the 8-year-old on that adult that might be the same size. Now, ultimately, your patients that have some really severe burns should end up in a burn center. Now, there may not be one very close to you. So you may have to take them to the closest appropriate facility, which any trauma center can take care of a burn patient. But being in that burn center, they're going to get that expert care, and they're going to get that ability to not only lessen the burn damage, but they're also going to get that burn care specifically for those types of burns, and they're going to be able to be rehabbed as well. So if your choice is level 1 trauma center or a burn center, in some cases, a level 1 will be okay initially, but they're still going to end up in the burn center. Now, once they're stabilized, if they're not at the burn center first, again, local protocols, local guidelines vary, but this is kind of a hodgepodge of what to think about when we're looking at the possibility of sending this person to a burn center or taking them there directly in some cases if you can. This may also be a consideration that if you're out in a rural area, that maybe this is a helicopter trip. You don't worry about grounding this patient because it's going to take an hour to get to the hospital. You call for the air support, and they can get them there in 15 minutes. Okay? They can bypass everybody else and get them right to the source where they have to go. So here are some of the general guidelines, and this is again by the American Burn Association for the most part. One is that any burn, now maybe excluding sunburn for the most part, but second, third, fourth degree burn, God forbid, right? Any of those burns to the face, hands, feet, joints, genitalia, or perineum. Any of those body surface areas goes to a burn center. And why? Well, it's not going to probably kill your patient, but those are more of long-standing orthopedic types of injuries that could affect their livelihood in certain cases as well. So those can be a big deal. Obviously, to the face, you got to also worry about the inhalation. So again, the soft tissue swelling, the carbon monoxide, the cyanide, hands and the feet. Obviously, we want to keep those intact as best as possible. In the joints, because again, if that gets scar tissue or not treated well, that could be, again, a major deficit as well. And then obviously the genitalia and the perineum goes without saying. Third degree burns in any age group. Now, some would have a percentage with this. If someone's got a third degree burn, they got a major problem. Right? They need it in a burn center. Any electrical burn, okay, including lightning strikes. But electrical burns in general, because of that internal damage I talked about, that could be a problem as well that needs to be monitored over a longer period of time. Chemical burns, okay, especially your alkali burns, because remember, they burn a lot deeper. Inhalation injuries we talked about, but you may have patients that have underlying chronic conditions. They have a history of cardiovascular disease. They've got a history of COPD. They've got other medical problems that could be exacerbated by the burn. Remember, the burns are going to cause a degree of dehydration and fluid shifting. So people with renal disease, okay, that type of stuff especially, all of them need specialty care. So they need that on top of the burn care, and the burn centers can do that for them. Probably would also go without saying that any child, okay, that's burned. There are children burn centers specifically, but even an adult burn center can take care of them temporarily in case they need to stabilize them. But they need that specialized care because their tolerance of this insult is much, much less than your average adult. Okay, so that being said, that's again some criteria, but always obviously you want to follow your own protocols and go by your own medical direction when making those decisions. If you found this video helpful, hit the like button and subscribe.